Hello, Richard Wells here again. I'm going to be presenting CBC News Now, a no-bullshit guide to the complete blood count. I have no conflicts of interest to disclose. Our learning objectives are here. This lecture is designed to meet the following end-of-week learning objectives. Interpret a CBC result, describe the clinical consequences associated with deficiency and excess of red cells and platelets, describe the clinical consequences associated with deficiency and excess of white blood cells, including neutrophils and lymphocytes. By the end of this module, you should understand the components of the CBC result, understand what erythrocytosis, leukocytosis, and thrombocytosis are, and their clinical significance, understand what anemia, leukopenia, and thrombocytopenia are, and their clinical significance, and understand what MCV and RDW measure, and their use in interpreting a CBC result. And now, back to the blood. You will recall that the blood comprises red blood cells, which are red and carry oxygen, white blood cells, which are not white but which fight infection, and platelets, which plug holes. And it's good to know, qualitatively, that these cells are present, but it's even better to know exactly and quantitatively how many of them are there. And to measure this, we use the CBC. No, the complete blood count. To the uninitiated, this may look like a huge, long laundry list of hematological esoterica. But I'm going to give you a way to think about the CBC that breaks it down and makes it more understandable. And I'm going to do this by relating the CBC to something with which you are all familiar, namely the barbarian province of Gaul circa 1 century BCE. You will remember from your studies of Caesar's Gallic Wars that all Gaul is divided into 3 parts. And so too it is with the CBC. It's divided into 3 parts: the life or death zone, the diff, and the hematologist zone. Let's go through these 3 zones in turn, and I'll tell you what they mean. First, the life or death zone. This is the CBC headline. This is what you need to know when you're in the operating theater or the emergency room. Life or death. So, we have hemoglobin, white cell count, and platelet count. So the raw numbers, the quantities of the main cells. Why do we have a white cell count and a platelet count and not a red cell count? That's because what's important about red blood cells is their ability to carry oxygen. And that's done, of course, by hemoglobin. The red cell count doesn't correlate precisely with the hemoglobin concentration because red cells can be too big or too small, and therefore they can contain, each cell, different amounts of hemoglobin. Hemoglobin is what we're after. So, in general, these cells can be present too much, too little, or just right. Let's go through. Too much blood. Too much red blood cells is erythrocytosis. Patients with erythrocytosis are red. As you can see on the right-hand panel, these are the hands of a woman with erythrocytosis. See how red they are compared to the hand of a woman without erythrocytosis on the left-hand side. The woman with red hands likely also has a red face. This is called a plethoric complexion. And erythrocytosis can occur either secondary to chronic hypoxemia, or it can be primary. This is called polycythemia vera. Next, leukocytosis. Leukocytosis means too much white blood cells. This can accompany a response to something like an infection or an inflammatory state, or it can go along with hematologic malignancy like acute leukemia, in which case the white cell count can be truly extremely high. In such a case, the white blood cells can stick to the walls of the microvessels and cause trouble. For example, as seen in the top scan here, pulmonary edema, or, as you see in the lower scan, cerebral hemorrhage. This is called leukostasis, and it's a very bad thing. Next, thrombocytosis, too much platelets. This can occur as a reactive phenomenon. For example, if someone has inflammation or infection, or along with iron deficiency, or again, it can be a primary overproduction of platelets. This is called essential thrombocythemia. In this condition, sometimes the platelet count can be truly gargantuan, and the platelets can be extra sticky, and they can block the microcirculation, resulting in, as shown in this horrible picture, gangrene of the digits. What about too little blood? Too little red blood cells is called anemia. You will recall that red blood cells carry oxygen, and so a patient who is anemic is not getting enough oxygen. They will feel tired, fatigued, and out of breath. And if you look at them, you will notice that they're pale. When you're examining a patient for pallor, you must examine their conjunctiva, as is shown here. You can't just look at their skin. Why not? Because not everyone has the same color skin, but everyone has the same color conjunctiva, and that's a more accurate place to look. Too little white blood cells is called leukopenia. Remember, white blood cells protect us from infection. And so when a patient has leukopenia, they're at increased risk of infection. Also, with neutropenia, specifically a deficit in neutrophil count, there's a classic association with what's shown in this picture, a neutropenic ulcer. And you can see right between the two thumbs in the gloves, a small ulcer on the inside of this patient's lower lip. Platelets plug holes. When platelets are in short supply, we call it thrombocytopenia. And patients with thrombocytopenia tend to bleed. On examination, you may find various types of bruises. This photograph of someone's ankle shows two types of bruises. There are the tiny red dots, about 1 millimeter in diameter. Those are called petechiae. And right in the center, there's a bigger coalescence of bruising. That's called ecchymosis, or purpura. Right, so that's the life or death zone. Let's move on to the diff. The diff is the differential white blood cell count, and it breaks down the total white blood cell count into its component categories. We've just reviewed in another video the 5 types of normal white blood cells found in the peripheral blood, and I've reiterated them here. Let's go through each of these. First of all, neutrophils. Neutrophils are particularly used to fight bacterial infection. And so we can see a high neutrophil count, that's called neutrophilia, in a patient who has an acute infection or in a patient with inflammation. It can also occur as a consequence of a bone marrow malignancy, most typically chronic myeloid leukemia. On the other end of the scale, a low neutrophil count is called neutropenia. Patients with neutropenia are at increased risk of bacterial infection, and the degree of increase in their risk depends on the degree of deficit of neutrophils. So a neutrophil count of between 2.0 and 1.0 is associated with minimal increase in risk of infection. There's a significant increase of risk when the neutrophil count drops below 1, and when it drops below 0.5, there's a major increase in risk. What about lymphocytes? High lymphocyte count is called lymphocytosis. This can be caused by stress, terror, certain infections, classically pertussis, whooping cough, and can also be seen with chronic lymphocytic leukemia. A low lymphocyte count, which is called lymphopenia, can accompany viral infections, think HIV, corticosteroid use, or various types of autoimmune diseases such as lupus. The monocyte count also can be elevated in response to infections, autoimmune disease, strange diseases like sarcoidosis, and also with a variety of hematologic malignancies. That's called monocytosis. A low monocyte count is pretty unusual. Monocytopenia can be a secret clue that a patient has hairy cell leukemia, and yes, that's really a thing. Now, what about the exotic cells? The rare basophils and eosinophils. If you look at the small print in the CBC, you'll see that the normal ranges for both of these types of cells start at 0. And so it's impossible to have a low basophil or a low eosinophil count. But the counts can be abnormally high. A high eosinophil count, eosinophilia, is seen with parasitic infections, with allergy and drug reactions, and can sometimes accompany Hodgkin disease, which is a type of lymphoma. If you see a high basophil count, you must think, could this patient have chronic myeloid leukemia? It's a classical association. Now, another thing that comes out of the diff is the phenomenon of the left shift. A left shift is when there are more than expected of the immature forms of granulocytes, metamyelocytes, myelocytes, and blasts. Now, why would we call this a left shift? It's simply because, traditionally, we draw the progression of granulocyte or neutrophil differentiation from left to right. So the most immature phase, the myeloblast, is way over on the left with Bernie, and then the most mature cell, the neutrophil, is on the far, far right with Ted. And a left shift just means that instead of mature neutrophils, we're also seeing bands, metamyelocytes, myelocytes, and sometimes even earlier forms. The left shift is what we see in a patient who's battling an acute bacterial infection. All right, now for the hematologist zone, and this is the true esoterica and small print. And I may be violating my hematologist code, but I'm going to tell you something that you'll find very useful. The hematocrit and the red cell count, if you already know the hemoglobin, are #worthless. The mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration, MCH and MCHC, are also, for any purpose I can conceive, #worthless. All you need to look for in this zone is the MCV, mean cell volume, and RDW, red cell distribution width. So MCV, mean cell volume, is a measure of the average size of red blood cells. And we've already encountered conditions where the red blood cells are abnormally large or abnormally small. This summarizes. When the MCV is high, greater than 100, you should think of liver disease, increased reticulocyte count, myelodysplastic syndrome, and B12 and folate deficiency. When the MCV is small, say lower than 80, think of lead poisoning, the anemia of chronic disease, iron deficiency, and thalassemia. And a handy thing to remember is the very smallest red blood cells are seen in thalassemia. The MCV can be down to the 50s. And the very biggest red blood cells are seen with B12 and folate deficiency, with the MCV up as high as 140. Now the RDW. The RDW is an interesting thing. It's a measure of the range of variation, or heterogeneity, of the red cell population. This graph shows the Gaussian distribution of red blood cell size in a normal individual. And the RDW is simply the coefficient of variation of this distribution. So normally that's between 10 and 14.5%. A common cause of an increase in the RDW is reticulocytosis, or the presence of an increased number of young red blood cells freshly hatched from the bone marrow. You can see in the panel on the left that we can identify these looking down the microscope. They're a bit bluish in color, and they're big. They're larger than old red blood cells. If you stain blood with a particular stain, new methylene blue, it stains the RNA in these reticulocytes, and you can identify them very specifically. And again, they're bigger than old red blood cells. And that's what's shown in the two distributions on the right-hand side here. So we have a normal blood specimen with an RDW of 14.8. You see there's just a tiny peak for the reticulocytes. If a patient has had a bleed and is recovering, or is battling a hemolytic anemia, he or she will produce many more new red blood cells in an effort to maintain red cell homeostasis. So the size of the reticulocyte peak increases, and that has the effect of widening the distribution. So when the RDW is very big, as here, 27, we say the patient has anisocytosis, not all the same. So this is a measure of homogeneity versus heterogeneity of red cells. So normal RDW very homogeneous, like Paul Ryan's interns. High RDW, very heterogeneous, like this refreshingly diverse group of people. Clear? All right. Now, what causes a wide RDW? I've already told you about reticulocytosis, for example, in the context of hemolytic anemia. Also, iron deficiency, vitamin B12 deficiency, myelodysplastic syndrome, and sideroblastic anemia. Sideroblastic anemia is a rare form of inherited anemia where there's a defect in heme synthesis. And I mention this mainly to show you this photomicrograph of peripheral blood film that shows very nicely the anisocytosis of sideroblastic anemia. You can see that there are some big red cells and some very, very small ones. Imagine the effect of that on the RDW. Now, there's one other little tidbit that is sometimes, but not always, reported in the CBC, and that's the mean platelet volume, or MPV. The MPV is like the MCV of platelets, and that can be helpful in sorting out the etiology of thrombocytopenia. Someone has a very low platelet count because their bone marrow is failing to produce platelets. The mean platelet volume will tend to be low. If they have a low platelet count because of immune destruction of platelets, for example in ITP, then the MPV will tend to be high. And so it's a helpful clue. So, are you ready for some CBC quizzes? Here's the first one. We have a 28-year-old woman who's come in with fatigue and a peculiar craving for ice cubes. Here's her CBC. What are the abnormalities? What could be going on? Pause the video and have a think. So, what do we see? She has a low hemoglobin, 86. Her MCV is low, 70.2, and her RDW is high, 18.8. It does occur to me that these red boxes have been moved and are not on the right things anymore, but you know what I mean. So she's got a microcytic anemia with anisocytosis. This means probably she has iron deficiency, and especially in the context of wanting to chew ice all the time, that would be top of my list. But other possibilities might include thalassemia, lead poisoning, and maybe the anemia of chronic disease. Next patient. We have a 42-year-old woman with recent onset of bruising. Here's her CBC. Pause the video and try to sort it out. Okay, so she has a frightening degree of pancytopenia. Her hemoglobin, white count, and platelet count are devastatingly low. And we see in the diff that her neutrophil count is low and her lymphocyte count is low. Low, 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 everything is low. This probably means she has bone marrow failure. That's by far the most likely diagnosis. However, if you were to find that she also had a massively enlarged spleen, it could be that this is all caused by hypersplenism. Next case. Now we have a 69-year-old man who's presenting with progressive fatigue. Here's his CBC. Pause the video and have at it. And what we see is that he's got a low hemoglobin, he's got a low-ish neutrophil count of 1.8, his MCV is increased, and his RDW is very high, 33. So, he's got macrocytic anemia, anisocytosis, and mild neutropenia. This sounds like myelodysplastic syndrome, but it's conceivable that he might have autoimmune hemolytic anemia, or B12 or folate deficiency, or even perhaps liver disease. You should think about how you would distinguish among these diagnostic possibilities. Okay, here's another one. This is a 61-year-old woman who had a routine CBC when she visited her family doctor for an annual checkup. Have a look at her CBC and see if you can figure out what's going on. Pause the video. And here we are. This is a very abnormal CBC. She's got quite slight anemia, but a very, very high white blood cell count, and also a high platelet count. Her RDW is just slightly above normal, and the diff shows high everything, high neutrophils, high lymphocytes, high monocytes. She also has quite a pronounced left shift and a very high basophil count. In fact, it's 10 times the upper limit of the normal range. Remember, high basophils think CML, and really, this can only be chronic myeloid leukemia. Now, do you know the characteristic genetic abnormality that's associated with CML? If you don't, you should, and you ought to look it up. So, by now, you should be able to understand the components of the CBC result, understand what erythrocytosis, leukocytosis, and thrombocytosis are and their clinical significance, understand what anemia, leukopenia, and thrombocytopenia are and their clinical significance, understand what MCV and RDW measure and their use in interpreting a CBC result. And with that, I will close our video and wish you a bloody good day.